Thank you for joining me today. In this video, you will learn dermatology conditions in a case study format. First case study that I have here is a Impetigo. Impetigo clinical presentation is that it is honey color crust around the nose, mouth, and mild itchiness. No fever. The primary treatment for Impetigo is a topical mupirocin 2% ointment that you will apply twice a day for 5 days. That is the first therapy for mild local impetigo. So as you can see, this picture is the child has a impetigo. There is a honey crust on the like acne, but it's the honey crust color around the nose, mouth. And the first treatment for impetigo is this medication, mupirocin. And 2% ointment you will apply twice a day for 5 days, and that is the first therapy. And it's good for mild and local impetigo without the systemic infection. Safety and monitoring are avoid ointment near the eyes. Watch for allergy reaction. Consider a systemic antibiotic if the lesion is spread or worsen. So if the lesion becomes spread or worsen and the child has or the patient has a fever, you will consider antibiotic. But if it's local and mild and no fever, no symptoms of systemic infection, you don't need antibiotic. Patient education, emphasize hand washing, avoid toilet sharing because this is it can transmit the impetigo. Trim the needle fingernails. Trim the fingernails and clean the surface for present transmission and recurrence. Because if the child scratch the lesion and if they touch somebody that they can transmit, they can also transmit the skin that is not having the lesion. They can scratch on the lesion and then touch different parts of their skin that can transmit the disease. And also if they touch with these fingers to other family member or friends or I mean school or work, that can transmit the disease. So you want to educate the patient to hand wash, to avoid to share their towel with anybody, and clean the surfaces of the house or where they touch. This case study is a cellulitis. Patient is presenting with cellulitis as a redness, warmth, swallow, tenderness with poorly demarcated borders and mild edema on the lower leg. Most people I saw who has the cellulitis, they have those symptoms. Causative bacteria and diagnosis. Common cause of cellulitis are strepto and staph. Diagnosis is a clinical base on a symptoms without virulence. So mostly it's a clinical base. You watch these symptoms. If the patient has these symptoms, they are not, the area is not oozing with virulent. That is the cellulitis. And the first line therapy is the Steflaxan, 5 milligram 4 times a day for 7 to 10 days. Targeting that antibiotic target is MSSI, strep with allergy and safety monitor. You want to watch the safety and monitor if the patient is allergic to that medication. If they're allergic to it, you will choose different medication, different antibiotics that they are not allergic to. Patient care and monitoring. Patients should mark the area. If they are in the hospital, mostly nurses will mark the area so they can know if the area is expanding or shrinking, or you will circle the borders of the area where the redness, warmth, and swallow and tenderness are happening with pain. And then you will educate the patient to elevate the legs so the swallow can go down. You will give them pain medication and educate them to complete the antibiotic that will improve 48 to 72 hours. That is the treatment outcome that you are expecting to see. This case study is a candidiasis. Candidiasis is a typical presentation, is affecting most skin folds. It affected most skin folds, showy bright red rash with subtle bubbles, common in the breast. Mostly I see under the breast, women or men, under the breast, under the skin folds. And treatment is a topical anti-fungus, because candidiasis is a fungus infection. Mostly could be powder or cream. And clatmatizole 1% are the effective and safe for breastfeeding mothers. Safe and precaution. Avoid irritation powders. Keep the area dry. So you will wash the areas, you will air dry the area, and then you will put powder or the cream, whatever you prescribe. Monitor the moisture and evaluate for recurrent infection. Signaling the other healing tissue. So you want to monitor the infection, spread of the infection. You want to monitor if the area is healing. You want to monitor if there is an allergy to the powder or the treatment. And the patient education include washing your hands so you don't spread the infection, wearing breathable fiber, so the air can get through that area and can dry the area. Continue treatment several days after the rash clears for full recovery. So you will continue the treatment until the area recovers. So this case study is acne, and acne involves hair follicles, hyperkeratinization, excessive seborrheic, C, acne localized, and inflammation as the main factors. Clinical presentation: patient shows moderate inflammation, acne with condones, pupillae, and pustules, mainly on a cheek and forehead. We all know what acne is. Combined therapy treatment include the night adapalene for normalized keratinization, daily peroxidate to reduce the bacteria and inflammation. Patient education include adherence, general skin care, photosensitivity, pregnancy risks to watch, avoid of a picking for the best outcome. So don't pick the skin area. This case study is psoriasis. Psoriasis is a chronic immune skin condition with rapid cell growth, causing thick, scaly plaques and inflammation. First treatment is a topical botane and corticosteroids are the first treatment to reduce the epidermal proliferation and inflammation. Avoid, and the patient education is, and the safety management is avoid calcitonia in hypercalcemia risk. It will increase the calcium in the system. Limit the corticoid to prevent skin atrophy and rebounds flares. You will educate the patient for should hydrate the skin, use lukewarm water, manage stress, understand the psoriasis is a chronic. So this condition is a chronic. It comes and goes with the stress and inflammation. This case study is a seborrheic dermatitis. Seborrheic dermatitis is a chronic inflammation skin condition affecting sebaceous gland, rich area like the scalp. Treatment approach is a ketoconazole 2% shampoo applied 2 to 3 times weekly is effective due to its antifungal properties and anti-inflammation effects. So you apply that shampoo 2 to 3 times a week. Avoid the eyes, expect possible dryness. An alternative with non-medication shampoo. Leave the shampoo on the scalp for 5 minutes. Patient education and treatment outcome. Educate the patient to minimize harsh hair products, moisture their facial skin. Expect the symptoms to improve 2 to 4 weeks. That is a dermatitis. This case study is a herb sample-X. It is herb it's SSB1 symptoms and triggers. So it's chronic and causes recurrent oral lesions triggered by the stress, illness, sun exposure, present with tingling and vesicles. Antivirus treatment, because it's virus, so you can only use that antiviral drugs. Aclafer 5% ointment every 3 hours for several days to reduce the symptoms severity. So you want to subside the virus, but it's chronic. It's not. There's no treatment for viruses, but it will subside the symptoms. Safety and prevention. Proper hand washing. Avoid mouth application to prevent the spread of the infection, the virus. Mild local irritation may occur. Avoid close contact during outbreak. This case is burns. Burn is characterized superficial partial thickness burn caused by the pain and blister, redness with moist redness tissue and intact sensation. So this is just a simple burn. Burn has too many layers and too many stages. This is just a simple burn. Topical antibiotic is like sulfur sulfadides cream, prevent secondary infection, and are applied daily. Avoid sulfur sulfadate in individuals with sulfur allergy. So if you are allergic to, or if the patient is allergic to the sulfadide, it will be sulfur, it will be allergic to this one. Infants under 2 months due to the risk like taras. Educate the patient to wound care, include keep the area clean, avoid sun exposure, change the dressing daily, monitor infection signs. This case study is scabies. Scabies go underneath the skin. Scabies is caused by Sarcobia scabia in mates and present with nucleosis itching, nighttime itching, and boring in the skin webs. So this goes to the under the skin and it will dig. Then the patient will be having an itch and scratch the skin. First treatment is benmatin 5% cream apply from neck down for 8 to 12 hours. Repeat after 1 week. So you will continue that medication 1 week. And that is the first line of therapy. This cream is the first line of therapy. Avoid ocular, avoid the eye. Expected treatment all close contact. Wash bed sheet in hot water to prevent reinfection. So you wash the clothes, you wash your hands and all clothes. Avoid oral exposure. And patient education is a persistent itchiness, post-treatment, improve of the environment cleaning, restore after 2 treatments will resolve. This will resolve after 2 treatments. This one is a lice. Lice happen is the scalp causing irritation, affecting mainly school-age children and is spread by the direct head-to-head contact. It causes scalp itch and visible nets on the hair shades. It happens school children mostly, but it also happens the unclean environments. Treatment is benmatin. 1% lotion is the first line of treatment applied to tame hair and is spread after several days for effective lice eradication. So this is how you do it. You apply the cream and you brush the hair. Avoid treatment in those allergic to the cream or this medication. Do not use condition before applying the lotion or toxic fumigation spritz. Educate patient, comb out the nets daily, wash hats and bedding in a hot water. Notify close contact to prevent spread. So you wet the hair, you apply the cream, you comb the hair, and then you prevent the spread of the lice. You will contact if you have been close contact with anybody.